we will address the early phase of chronic hepatitis C infection, and that's the acute hep C infection. My conflicts of interest up front. And I would like to start with a clinical case with a patient, 41 years old, HIV transmitted via sex with other men. Diagnosis was made in 2004, and he has quite a history of other STDs, HPV, syphilis, chlamydia, and gonorrhea repeatedly, and he was put on antiretroviral treatment in 2005 and has been on nevirapine and Truvada since 2011 and had to switch his ART twice because of intolerability. With atazanavir it was hyperbilirubinemia, and with efavirenz it was CNS toxicity, but he's now very stable and well on Viramune and Truvada. And he shows up every 3 months for his regular HIV checkup and has left the clinic, didn't complain of any specific signs, symptoms, or problems. And the fax report comes out of the machine in the afternoon, and you can clearly see that there's been a change in the liver enzymes, so leading by ALT 129, so clearly there's something going on in the liver. And of course, the title is acute hepatitis C. He's suffering from acute hepatitis C infection, high viral load. He is already anti-HCV positive, and the last negative results we had was 10 months prior. It's the genotype 4A infection. That's in the Rhine area in Germany, the second most common genotype after 1A. We've just learned yesterday that it's 1B in northeast and northwest of your country. It's rather 4 or 1A in the western parts of Germany. And syphilis, which we also had to test for due to his elevated liver enzymes, was negative. So what actually is an acute hepatitis C infection? There are clear definitions now by the European AIDS Treatment Network. It's a positive antibody result, and then you also need a PCR or antibody result. If you don't have previous test results because the patient is new at your department or was newly diagnosed with both infections, you can also make the diagnosis with ALT values. It's rather important to keep the ALT elevation in mind as the main leading, let's say, finding that triggers the diagnosis of acute hepatitis C infection, because especially in HIV-positive patients, the symptoms of an acute HCV infection are rather mild, and compared to HIV monoinfected negative patients, the patients are less likely to show any clinical signs or symptoms, which you can see at the bottom. So that's an analysis of our German acute hepatitis C mono and co-infection cohort. You can see that only a third of our patients will actually have clinical signs of an acute hepatic illness, compared to almost 60% in the HIV negative. So the patients won't really tell you why they show up at your clinic that they actually have an acute hepatitis C infection. ALT elevation actually occurs in 88% of acute hepatitis C infected patients with HIV, and more than half of the patients will actually have an increased ALT, which is upper than 5 times the upper limit of normal. You can't really rely on antibody test results alone, because especially in HIV infected patients, this is what Emma Thompson has shown us some years ago, the development of antibodies, not only for HCV but in general, can be delayed, and that could mean that 5% of your patients still haven't developed any anti-HCV antibodies 1 year after the infection. So you can't really rely on positive antibodies to make the diagnosis of an acute hepatic infection in the co-infected patients. You can clearly argue now this epidemic has been going on for quite a while now, especially among IVDUs and later on MSM. Is this still relevant today? Yes, it is, and it's a worldwide phenomenon. These are the most recent data we can get from the United States. That's from the CDC. You can clearly see that there's been an increase, at least in reporting cases of acute hepatitis C. And we have looked at the same question in the EuroCEDA cohort, and you can again see an increase in positive HCV antibody tests. That's the blue line, but you can also see that physicians and patients are becoming much more aware of the illness, and the test rate itself is increasing as well. When it comes to risk factors, the data are less conclusive at the moment. This is again the CDC analysis, and you can see in dark red that in almost 40% of all reported cases, there were no data available on possible transmission risk factors. In the other 60%, there were some data available, and that would be the classic transmission risk groups, IVDU, and men who have sex with men, and then a group with multiple sex partners. But again, the yellow bars show you that in most cases, no risk factors have been reported. The best idea we can get what's actually the driving factor among HIV-positive MSM for transmission of acute hepatitis C could be the data from one German analysis that Axel Schmidt conducted quite a while ago. He handed out questionnaires to patients at HIV GP offices throughout Germany, and the patients were asked anonymously to report on their sexual practices, rather detailed. And it's very small print, I apologize, but you can see that there were statistically significant associations with nasal administration of cocaine, which can cause mucosal trauma. And if you share a straw or any other sniffing device, you can get contaminated straw, and then if your mucosa is damaged, the HCV can enter your blood system, and the other risk factor would be mucosal trauma during sex. If we come back to our patient, of course, he showed up rather more often than the usual follow-up visit because we had to check his liver enzymes, and 4 weeks after the diagnosis, we also made again a hepatitis C RNA, and that was 2.5 international units. And why is this 1 month interval of importance? Because it can clearly tell you if this patient will spontaneously clear his acute hepatitis C infection or if he will go to a chronic cause. Between 0 to 40%, there's a wide range because the data are based on different cohorts. But as a rule of thumb, the likelihood that your patient clears is around 15%, 20% if you're lucky. And this you can tell your patient when you've got the week 4 HCV RNA result. If he shows a drop of more than 2 log in his viral load, which our patient didn't, your patient will probably spontaneously clear his acute hep C infection. If he doesn't show a drop, which is the case in our patient, it's very likely that the acute infection will lead to a chronic cause. Then, of course, our patient asked, what can we do? Is this something we can treat? And yes, compared to HIV, at least we have got the chance to really cure people of hepatitis C. And he immediately asked what the treatment recommendations were. And this is now, fast forward to 2015. And the EASL conference just took place in spring this year in Vienna. And they have also updated their guidelines with regard to the acute hepatitis C part. And in the very developing, exciting world of interferon-free DAAs, you can still see there's some room for interferon, especially in the acute setting. So for patients who don't have HIV and are acutely with hep C infected, you can use PEG interferon monotherapy. And in co-infection, they recommend still pegylated interferon and ribavirin for 24 weeks if you respond quickly. They also state that you might use DAAs, but there's no really clear guidance at the moment which this would be. So the strict recommendation at the moment would be interferon ribavirin in co-infected patients. So our patient started treatment according to the EACS guidelines, and as he was weighing more than 75 kilograms, he was given ribavirin 1,200 milligrams, that's 6 pills per day, and he came in quite often for monitoring of blood count and liver enzymes, and his HCV RNA dropped down to close to 4,000 international units at week 4, and he was complaining of fatigue and headache from week 4 onwards. This week 4 HCV RNA level, again, is very important to determine the duration of treatment. If your HCV RNA level is negative at week 4, you should go for a 24-week course. If it isn't, and that's the case in our patient, you should go for 48 weeks of treatment. That's what he did. So he's been undetectable since week 12 and was undetectable at the end of treatment, and then he also reached SVR, which at that time was still 6 months after the end of treatment. Comes in again 3 months after his SVR time point, usual HIV checkup. No specific complaints and no clinical signs of any ongoing illness. And in the afternoon, again, the fax report scrolls out of the machine, and there's again an elevated ALT, and 3 months prior it was normal. So what could this be? It's again an acute hepatitis C infection, and you could well argue if this is a relapse of the previous infection, maybe that wasn't treated properly and just has reoccurred. But in this case, he has got a new genotype, so it really is a new infection, this time genotype 1A. And he also managed to contract a syphilis. And this is clinically not a rare setting. If you look at centers that treat a lot of HIV-infected patients with acute hepatitis C infection, the reinfection rate can be up to 25%. So a quarter of your patients will get a second acute hepatitis C episode after the first one, if you look at centers that are really focused on these two diseases. Our patient, like the previous episode, came in again 4 weeks after the diagnosis. Again, very, very high HCV PCR. So again, no clinical likelihood that he will spontaneously clear this infection. And of course, because it's now 2013, he was asking, I've heard some rumors, there are treatments where I don't have to take the interferon syringes anymore because it worked well, but I didn't really tolerate it. I was complaining of fatigue, headache since week 4. So the question really was, can we prescribe DAAs in this setting? And the possible scenarios that we could look at would be interferon ribavirin plus one of the then new hepatitis C protease inhibitors, or just take out the ribavirin completely and just go for sofosbuvir plus the interferon completely and just go for sofosbuvir and ribavirin, or really delete the so-called old treatment and just focus on the DAA and do a combination approach of maybe sofosbuvir and the dipasvir. And I will try to show you some evidence for each of these scenarios now. So we do have some cohort data on the use of telaprevir with interferon ribavirin in the setting of acute hepatitis C infection. These are data from New York, and in total 90 patients were treated for, as you can see, 3 months. Interferon ribavirin and telaprevir. So it's a shorter duration of treatment just by adding the hepatitis C protease inhibitor, and they saw a success rate of 84%. And they also had to look at their other patients that weren't eligible for telaprevir or were treated before telaprevir was licensed in the US, and had a comparator SVR rate of 32. If you keep in mind that in our acute hepatitis C cohort, the success rate is around 70%, you probably gain 10 to 15% just by adding the hepatitis C protease inhibitor telaprevir in this setting. And there's also now data from the Netherlands presented at this year's CROI. And when you look at the SVR rate, it's 76.5, so it's really going down, and the delta you get just by adding an hepatitis C protease inhibitor is in this cohort just around 7 to 8%. But what we can see is that the physicians and patients are less inclined to start treatment with interferon ribavirin because everyone is anticipating that we will have DAAs soon. Also for the treatment of the acute setting. These are data from the large European acute hepatitis C cohort. You can see after the licensing, at least of the first HCV PIs took place in Europe, subsequently the treatment uptake rate went down. So what can we expect in terms of interferon-free regimens for the acute hepatitis C setting? So we've tried to compile a table listing the trials we are currently aware of that are assessing DAAs in the acute HCV setting, mono or co-infected patients. I've just shown you data from the Netherlands cohort. We will shortly see some data from our own cohort in Bonn. The Australians are very busy as well in assessing DAAs in HIV negative and positives. And there's currently a study ongoing assessing dipasvir and sofosbuvir in the setting of acute hepatitis C infection. co- and mono infection in Germany and the UK, which I will also show you. So the study design of the CHET study is similar to the New York data we've just seen, but we managed to include a control arm because we really wanted to see what's the benefit of adding telaprevir compared to interferon ribavirin alone. We managed to screen 15 patients, one failed, and we have SVR12 data in 13 out of 14. What I really would like to highlight is that the SVR rate so far among the telaprevir-treated patients is far less than anything we have seen so far, and that mainly goes back to patients that actually didn't respond to the triple treatment, non-responders. And I will just show you one case because he happened to be my patient. He started at baseline with a very high viral load, responded very well at week 2, and there was a slight increase at week 4, and then we brought him in after we got the PCR results and did a retest. And it was even, the HCV RNA was even increasing 4 weeks after initiating triple therapy. So the reasons are the same we just discussed. It could either be a reinfection, so maybe he just contracted a different genotype, which is not covered by the hepatitis C protease inhibitor, or because these are now directly antivirally acting agents, he could have actually developed hepatitis C protease inhibitor resistance. So we did a resistance testing at this time point after the genotype was compared that it's still the one he started treatment with. And we could see that we actually have hepatitis C protease inhibitor resistances for 36M and R145K, which are very likely to develop under telaprevir. And the second question, of course, then was, is this something that was already existing when we initiated treatment because we didn't do any resistance testing at baseline, or was this something that developed under the pressure of the drug? Because at this time point, there was a new report from Spain describing a couple, an MSM couple, where the one partner was treated during his chronic phase with HCV protease inhibitor containing treatment, and he failed due to resistance development, and he managed to infect his partner, and the resistant variant could also be detected in his partner. So that was the first case of really transmitting a resistant virus of hepatitis C. We were lucky enough to find a sample of this patient at his baseline time point and did a resistance test again. And as you can see, the resistances we saw at week 4 weren't there at baseline, so these resistances really developed under the pressure of the drug. And that clearly tells you that in the acute setting where the viral is very, very high, the drugs might behave differently than we see in the chronic phase. So we really need clinical trials that assess these DAAs in the acute setting. And one of these will be the currently enrolling SALT study, which has been taken over by Gilead. And we will include patients in the acute hepatitis C setting, and they will be treated for 6 weeks with sofosbuvir, very easy, 1 pill per day. We will include 20 patients, and are very keen to see the results rather quickly because we're looking at a 6 weeks treatment course. But the question, of course, is these trials are still ongoing. What if tomorrow you've got a patient who's coming in with a new diagnosis of acute hepatitis C? What can you tell him? Firstly, you can tell him he's not going to die of his acute hepatitis C infection, and the potential that this causes any liver damage within the next years is very, very low. That's again data from our acute hepatitis C cohort in Europe. You can see that the fibrosis development is mild, if any, over a couple of years. But on the other hand, you still have patients that are going to chronic phase, and which gives the potential to transmit the virus to other sex partners. So you're really you're sitting in between two chairs, the individual perspective and sort of the global public health perspective. So the question really is, what do we do with our patients today? And it can only be an individual decision that you have to discuss with each patient individually. If the patient wishes immediate treatment now, you could try pegylated interferon ribavirin. If side effects occur, you could stop the treatment rather generously because you will have the potential to cure at the chronic phase. Another argument could be that you want to reduce the transmission risk. It's a cheap therapy compared to the DAAs. And if the patient goes on to a chronic phase because he doesn't want to take interferon, he will probably end up with some years with hepatitis C infection, because at the moment most DAAs are only reimbursed if you've got F2 fibrosis or higher, so you really need the hepatitis C virus to cause some damage in the liver, so to say, to be eligible for any DAA treatment. Contra, of course, would be the toxicities, ribavirin and interferon, the rather long duration of treatment compared to 8 to 12 weeks in the chronic phase. They are well tolerated, and the liver itself won't get any serious harm within the first years after this acute hepatitis C episode. Thank you.